Hello and welcome. Today we have with us Dr. Shelsey Johnson. She's a primary author on the latest manuscript, which was released today in Critical Care Exploration. Dr. Johnson, welcome to our channel.
Hi, good to be with you guys.
Yes, Dr. Johnson is a third-year pulmonary and critical care fellow at Boston Medical Center with Boston University, and she has been involved from day one on this global virus COVID-19 registry led by CCM Discovery Group. And we are congratulating here Dr. Johnson for her recent publication. Please accept our congratulations and tell us what are the main results from your manuscript.
Thank you, Rahul. Good to be with you guys. So as many providers probably know that manage these patients early on in 2020 and through the last 2 years, one of the main kind of observations as clinicians that we had early on was that we did not have any treatments for these patients, but that what we could rely on was prior data that we've gathered over the last 20 years in terms of how to best manage patients who present with ARDS. And so in that first year of managing patients and the resources that we built through the SCCM COVID virus registry database, we wanted to look and see how well were people complying with guideline-based care for ARDS management. And so what we mean by that is how often were people using, one, low tidal volume ventilation? How well were people complying with plateau pressure targets less than 30? And then third, how often was prone positioning or prone ventilation being used in our cohort for patients with severe ARDS, which we defined as a P to F ratio less than 100. So that was the main question we had. And then we wanted to look across hospitals, both in the US and internationally, and see how well were people complying with these guidelines and what was the variation in use of these parameters across hospitals.
Fantastic, such an important question. And we all were wondering as a providers and researcher that, can we find out where the compliance is or what is the variation in the hospital practices? So tell us, what are your main findings from your publication? Where do you start with? And then what are your main message coming out from your manuscript?
Yeah, so early in the pandemic, Dr. Walkie and yourself and others from SCCM came together and built this very novel registry of COVID patients internationally. And from that, we were able to distill about 1,500 adults with ARDS that were hospitalized at both international and US-based hospitals. So 1,500 patients, 42 hospitals. And what we found was that only 50% of patients ever received all care consistent with guidelines. So that means all three of those parameters were met. And that across hospitals, there was variation in use of these parameters. So the range was from about 40 to 60% across those hospitals. And then if you looked at the hospital itself as kind of the factor to explain that variation, hospital of admission contributed 14% of the risk-adjusted variation in that use. And kind of explaining that further, we found that if you were admitted to a hospital with high use of those guideline-based care practices versus low use of those guideline-based care practices, you were 2 times more likely to receive those guideline-based care therapies. And then as an exploratory outcome, we looked at mortality, and we kind of sectioned patients into quartiles, and we said, okay, if you're at a hospital with the highest quartile of use of that guideline-based care versus the lowest quartile of use of guideline-based care, what is your mortality? And we found a non-statistically significant but relevant association with mortality, in that those treated at the high guideline-based care use hospitals had a mortality of 49%, whereas the low guideline-based care use hospitals was as high as 60%. And so that was really interesting to us, and kind of what we would expect is that when you use, management strategies for ARDS that we've borne out in the literature over years that are associated with mortality, our patients do better.
These are such a bigger differences, even though it did not reach the statistical significance, but 60% versus 49% difference is a huge difference. And so kudos, first of all, for having those methodology and statistical tool to actually detect it and so on and so forth. Were you surprised with any of these results, or is it something you were expecting that it might be, there's a difference? You know, not all hospital could be the same, but what was your first thought when you saw the initial preliminary results?
So we obviously looked at what factors are associated with use of guideline-based care. And the kind of two main variables that were associated with use were female sex. So if you were a female, you actually had a 53% decreased odds of receipt of use of guideline-based care, which was somewhat surprising, but has also actually been reported in prior studies and has been attributed to our default title volumes that we use kind of as determined by patient height. And so that was, I think, surprising and interesting, but kind of nice to see that it's already been shown in the literature as, to corroborate our findings. And then severity of illness was also significantly associated with use. And that was a little bit surprising in that patients with moderately severe ARDS, with a P to F ratio in the 100 to 200 range, they were more likely to receive these guideline-based care therapies, whereas those with severe disease were less likely. And we found, especially in those severe disease patients, that it seemed like that plateau pressure target, less than 30, was less commonly used in that group. And so I think what that may represent is that, these patients with very poorly compliant lungs, it's just that much harder to comply with those guidelines. But it may be an important group to focus our attention on. The other thing I'll say is that for proning, we actually saw that 62% of patients overall that had severe ARDS received proning, which is actually higher than previously reported cohorts that have been in more of like the 15 to 30% range. And I think that may be a product of a lot of the literature coming out early on about self-proning and optimizing VQ matching in these patients as one of the only therapies we really had.
Perfect, thank you. I think that kind of reminds me that what are the opportunities? First of all, is that the disparities also, when you see that, the women were less likely to receive best practice guidelines, it's no shocking, there are other disparity things as well. So thank you for pointing that out, and maybe there's an opportunity for investigators or researchers to look into it, and especially policymakers. It reminds me of the publication came out last year from another SCCM discovery study called SAGE Group, and they had like one of the biggest peacetime ARDS database as well. So do you see an opportunity for collaborating and actually looking at a pre and post kind of data and seeing if the differences were similar, or did they get worse compared to pre-pandemic compared to post-pandemic, because that was a pre-pandemic largest ARDS database in the country through SAGE study. It's run by Dr. Nida Kadir, Dr. Michelle Gong, Dr. Raquel Bartz, and then and Dr. Pauline Park. I see an opportunity where to collaborate and then kind of pull the data from pre-pandemic time and this pandemic data to see if it gives you a pre and post kind of design.
Yeah, definitely. I think what was, very unique about COVID-19 was that ARDS is such a heterogeneous syndrome. And so I think something that we felt was very novel about this study was we thought our patients were relatively homogeneous and that they had the same insult that was leading to ARDS. And so, I think especially comparing a sample in which we've studied ARDS previously to this kind of more isolated insult leading to ARDS, and would definitely be interesting.
Absolutely. Well, what is your take-home message for the clinicians, doctors, nurses, respiratory therapists who are watching today? What is the take-home message for them? Any 2 or 3 pointers for them to take it from your study?
Yeah, I think there was a lot of discussion early on in the pandemic about whether the physiology of COVID-19 ARDS was different from the ARDS we had seen, we've seen for so many years. And there were a lot of editorials about, different compliance and whether these patients should be managed differently. And I think what our study really showed is that among patients who received guideline-based care, which has been borne out from ARDS literature over the last 20 years, there was a trend towards improved mortality. So focusing on those strategies for the management of these patients, as well as obviously incorporating all the new treatments that have been, identified over the last 2 years for COVID-19 are really important, and that there's variation across hospitals and how well we comply with these guidelines. And so anything we can do as providers at the bedside, teaching, residents, fellows about the benefits of these therapies and complying with them is very important.
Absolutely. Well, we would like to thank you not only for taking on such an important project in spite of all busyness and other obligations, but also thanking you for being on the front line, treating sick patients during the pandemic in these 2 or 3 phases. We already have seen it. And thank you so much again for being with us today for this interview.
Well, I thank SCCM for the opportunity to get involved with the data set, which allowed us to, look into these questions. So thank you.
Absolutely. Absolutely. Thank you. And then viewers, please like, subscribe, and write in comment section what you liked from Dr. Johnson's interview, and let us know if you want her to come back with more questions for you as well. Thank you so much for watching today.